Good afternoon, and thanks for joining us for today's Healthline 3. I'm Johnette Magner. This is where we like to focus on ways to live a healthier, happier, and pain-free life. And we're also going to be taking your calls and answering your questions live in studio today. We will be opening the phone lines shortly. As a reminder, if you want to call us, please make sure you are in a quiet room when you call with your TV turned all the way down. Our number is 318-219-4569. Again, that number 318-219-4569. And today we are talking with Dr. Stavan Patel. He is an oral and maxillofacial, did I say that right?
Yep, maxillofacial.
Okay.
Yeah.
And surgeon, and we're going to discuss surgical management of obstructive sleep apnea. All right, how about we start with just defining sleep apnea?
Yeah, pretty simply, sleep apnea is a obstruction of your upper airway, and the way we define an upper airway is basically the airway between kind of your larynx, your voice box, and your nasal and mouth passages. And so it obstructs when you go to sleep. It could be a partial obstruction or a complete obstruction, and then when it obstructs, you don't have sufficient air going to your lungs, and so your oxygen saturation suffers and other things can happen. So yeah, obstructive sleep apnea is exactly what it says. It's obstruction of your upper airway.
You know, sometimes we laugh about snoring, right? But sleep apnea is actually really dangerous.
It is.
Talk about the different ways, please, that sleep apnea can harm your overall health.
Yeah, sleep apnea, you know, it's very underdiagnosed in a lot of our population as well. And because it's underdiagnosed, it can affect a lot of your health. And so some of the health issues that you can have is just kind of endocrine issues, right? So you can have insulin resistance and type 2 diabetes because of sleep apnea. You can have cardiovascular issues, so you can have issues related to possibly having a heart attack if it's undiagnosed and continues to persist. You can have arrhythmias, you can have high blood pressure. You can have neurologic issues because of it, such as having a stroke potentially. Or you can have kind of brain fog, memory loss, like simple things like that can happen as well. So yeah, I mean, a lot of those things are very important, and we don't realize that that's happening because of sleep apnea, because it's not being diagnosed. So yeah, you know, and obviously you wake up very tired next day. You're constantly tired, and you're trying to figure out, why am I so tired? Because you feel like you're sleeping 7 to 8 hours, but you're not, right? So when sleep apnea happens, your sleep cycles break because you're waking up gasping for air. And so that happens, you're frequently tired. And one of the most dangerous things about sleep apnea is people feeling tired at work, people feeling tired when they're driving. When, you know, you see people falling asleep when they're watching TV. That's benign, all right, but that's okay. But at the same time, if you're tired at work and falling asleep at work, that can be dangerous depending on the type of work you do. And certainly when you're driving out on the road, you can be dangerous to yourself and others. And we know that we have a lot of people, a lot of accidents around the country that happen when people fall asleep while they're driving. And a lot of them are due to undiagnosed sleep apnea.
Wow, definitely something to pay attention to.
Yeah.
Do you often find that people come in and say, my wife says I have this, or my husband says that it's something that is diagnosed by your partner?
It is, and it actually happens most of the time. And so when the spouses come with the patients who are referred to us for evaluation, and they'll say, yeah, I have to wake him or her up because they haven't taken a breath for 20, 30 seconds. And they'll tell us, you know, oh yeah, they keep sleeping, but I'm more anxious because I'm sitting there and trying to figure out how long is it going to take you to take another breath. And so yeah, they nudge them and try to wake them up. And you know, a lot of times one of the treatments for mild sleep apnea and one of the lifestyle changes that people do, we suggest that they do, is rather than sleep on their back, is sleep on the side. And so you know, the spouses poke them until they sleep on their sides, and once the patient goes to the side, then they can actually breathe a little bit better, their airway can stay open a little bit more.
Do certain types, I mean, I would think maybe weight has something to do with it, gender, age. What are some of the variables that make you more susceptible?
Yeah, I think you know, you're getting all the ones that, you know, yes, age greater than 50. is one of the indicators where you're more likelihood to have sleep apnea being of male gender. Now, that being said, male gender is separate from just age, and so at about 50 to 55 years of age, men and women being diagnosed with sleep apnea becomes equal, and it all has to do with a lot has to do with just us aging, and then just having a lot more fat deposits, right? So generally speaking, women have fat deposits not in their central area, men do, and as women get postmenopausal, they'll have more central obesity, more weight gain, specifically in the abdominal area, and then also in the neck region. And when you have that, that just compounds and causes sleep apnea to be more profound in those age groups. But yeah, age, gender, you can have a genetic predisposition, so you can have a family history of sleep apnea, and so if you have family members, other family members who have sleep apnea, you are more likely to be diagnosed with sleep apnea. So those are certainly some of the factors which kind of say, okay, well, it predisposes you. And so these are the factors that we cannot control. Now, having obesity by itself doesn't mean that you're going to have sleep apnea, but it does 55%, it depends on which papers you kind of read, but anywhere from 30 to 50% of obese patients will have sleep apnea. So it does put you in a different category for having sleep apnea. Other things like having low thyroid hormone, right? So if you have undiagnosed hypothyroidism or low thyroid hormone, or increased insulin or growth hormone in your body, they'll also put you at a higher likelihood of having sleep apnea. But some of those things could be modified. Like if you have low thyroid hormone, it's a simple thing. You just go and get your thyroid hormone replaced, right? It's a medication that you take every morning. But then there are other things, just medical conditions like having congestive heart failure or having kidney disease. And what they don't directly affect sleep apnea, but they cause your body to retain more fluid. And when it retains more fluid, everywhere else, it doesn't affect sleep apnea, but when it affects between here and has more fluid between this region, the tissues become more edematous. And so basically what we're talking about is we have a pathway to breathe, and that area decreases, and then when you fall asleep and you're older, all that tissue is lax, it just collapses and causes sleep apnea. So yeah, there are many factors, but some of these we can change, right? Congestive heart failure, the internist can work on getting it treated. Same with kidney disease, to the best of our ability, we get it treated. But there are certain factors which are anatomic factors, which you're born with a lot of times and which you cannot change at all. And those things are like having a small undergrown jaw, for example, or a large tongue, for example, long soft palate, that's the roof of the mouth, or your hyoid bone, this bone that kind of suspends the larynx and the base of the tongue, can be very low as well. And if it's low and further back, then it will also cause more obstruction in your airway. And so all those things you can't change, but some of those things, well, you're born with, I should say, or nasal passages, for example, like allergic rhinitis, right? So if your nasal passages are not open, you can have more obstruction in that area. But some of those things we can treat earlier on. So specifically related to the jaws, and we see a lot of these patients earlier on in life, is younger kids in their mid to late teens. They'll come in and they have just severely small jaws, and so we have them see an orthodontist who will try to intervene early. Like if we catch a lot of these kids when they're 9, 10, 7, 8, 9 years old, we'll make sure that the orthodontist sees them early, and they do palatal expansion. They allow for expansion of your lower jaw, and so they're creating ways to increase space within the oral cavity so you can breathe a little bit better. So all we're doing, our goal is to have more air go through your nasal passage and your mouth to be able to aerate your body, basically, give enough oxygen to your brain and the rest of your body. So yeah, and then if we do think that they're surgical candidates, then we would want to intervene early. Same with tonsils and adenoids. Like when we talk about kids, that's the primary thing, right? If you're diagnosed as a child with sleep apnea, the first and foremost thing that we do, and we suggest we do, is to remove their tonsils and adenoids. That's the gold standard of treatment in kids for sleep apnea. And so I think it's important that we treat things that we can, but sometimes there are other things that we can't treat, and then you come in late, or you have not realized that you may have sleep apnea, and then we just have to treat it later on in life.
So let's talk a little bit more about the surgical options for sleep apnea, which is what you specialize in.
Yeah.
But what all are you able to do for people?
Yeah, we're able to do quite a few. It's a big basket of tools, right? And it's like a workshop kind of deal analogy. It's not every tool is for every patient, right? And so the key is to figure out where the obstruction is. And if I may step back a little bit, to figure out where the obstruction is, we first have to diagnose sleep apnea. And to diagnose that, we need a sleep study. And there are some questionnaires we use, and then we get a sleep study, and then we diagnose where the obstruction is, and the diagnosis happens with multiple modalities. You get a CT scan, an MRI of your facial skeleton and your neck, and look at the airway. And then the other thing you look at is we put them to sleep. We sedate them really heavily to a time where they start snoring. And so they're obstructing, and we put a scope down their nose and look exactly where the obstruction is. And so based on that, then we say, okay, well, we'll treat this area of obstruction with this particular surgical modality. And so just to give you an example, if the obstruction is in the nasal passages, and it is because of a trauma that you had earlier on in life, and you had a deviated nasal septum, you could have it developmentally as well. But if you have that, then the fix is very simple. And you're a nose breather and you're obstructing, you go fix the septum, done. Or the nasal valve is collapsed, you fix that. So that's just that level of obstruction. If it is in the back of the mouth where the soft palate is, then we just do something called a uvulopalatopharyngoplasty. It's a very long word, but we call it UPPP. It's U and 3 Ps. And it's basically we're removing the uvula, this part of the soft palate, and then we're tightening the muscle sling back there so it's not collapsing every time you sleep. So, but again, if that's where it is. Now, if it's the oropharynx, the back of the mouth, if it is the base of the tongue, if it is the hyoid, then we would opt for different surgical options. For example, something called MMA, or maxillomandibular advancement, or possibly use an Inspire device if it is just in the base of the tongue area and the hyoid region. We can resuspend the hyoid forward as well. So there's loads and loads of tools based on where the obstruction is. Other things which are also implemented, something called bariatric surgery for obese patients specifically who are having a hard time with weight loss. And we've tried everything else, and diet and exercise and education, and the patients are really invested into wanting to get your sleep apnea treated. Bariatric surgery, I think it's a great option. I don't do bariatric surgery, but we have fantastic bariatric surgeons in town, and so I think that's an option. And then there's really radical options. We have certain patients who are not candidates for various reasons for having sleep apnea surgery at any level. And so just because either they're very obese or they have some craniofacial dysmorphism where there is no way to treat them, and so then we have to do the final treatment in sleep apnea surgery, unfortunately, is a tracheostomy, as you bypass everything from here to here and create an airway within the neck, which the patient has to live with either forever or for a very long time until we can figure out how to undo the obstruction that is in the upper airway. So yeah.
Wow, that is definitely the result you don't want to have.
No, you don't want that.
So somebody who has sleep apnea, do they come to you first, or do they go to a sleep medicine doctor?
Yeah, that's a great question. Yeah, they'll actually go to their medicine doctor probably first, just like internist or family medicine doctor. And so, well, usually their spouse will say, you need to go see somebody. You're snoring too loud, you're not sleeping, right? So you go to your internist. And most of the time, the internists are very good at kind of screening patients. And there is, how we screen for lung cancer and prostate cancer and all these different things. There is no nationalized age-based screening for sleep apnea. There's one population that they screen in pilots. and because you don't want your pilot falling asleep while they're flying the plane. And so they do get screened, and they do have to be treated, and it's a very intense management that they have to be under. FAA requires that. But that being said, there is no other subgroup of patients who need to be, get screened on a routine basis. So, but yeah, the internist will generally do screening, and we have really a lot of great screening tools, but the two common screening tools, one's called the Epworth Sleepiness Scale. It's a mouthful, and the other one's called a Stop Bang questionnaire. They're both very validated questionnaires. The Epworth Sleepiness Scale, it's just a set of questions, not many, about 6 questions, and basically what they're looking at is it's a sleepiness scale. It's saying how tired are you from your sleep apnea or potentially having sleep apnea. What they're screening is, do you have sleep apnea or not? Do we need to get more studies? And so that scale rates, basically asks you questions like, oh, if you sit around at work, do you fall asleep? Yeah, if you're driving a car, are you falling asleep? If you're having a conversation with somebody, are you falling asleep? And this can happen. And so, or if you're at a stoplight while you're driving a car, do you fall asleep? And so basically you rate these questions, and you know, the scale is from 0 to 24. And if you score more than 9, then there's a good chance that you probably have sleep apnea and that you may need further studies. The other questionnaire is this, it's called Stop Bang questionnaire, and it's an acronym. And so, you know, if stop, S is like snoring. It's like, and it's actually loud snoring. It's like, how loud do you snore? And the question asks, do you snore loud enough with closed doors where you're sleeping that somebody in another room can actually hear you? and so it's a yes or no questions. All 8 questions are yes or no. And so, you know, so you say yes, okay, all right, so that's 1 point. And it's 8 points. And so then the next one is T. And T is tired. So are you tired? Are you sleepy? It's just like the Epworth Sleepiness Scale, right? So are you tired? Yes or no, next day, all the time. And so yes or no, okay. And then so the third question, STO, is observed apnea. And so what that means is, has somebody seen you stop breathing, basically? So yeah, your spouse, like, you know, nudging is like, hey, breathe. You know, it's like, yes, somebody's seen you. So it's a yes or no question. And then the next one is pressure, P, is blood pressure. Do you have high blood pressure that you're being treated for or not treated for? So those are still a little bit more subjective, more close to the Epworth Sleepiness Scale. But the last 4 questions are very objective. And the BANG part, so the B is BMI. And so these are, again, yes or no questions, right? So the B is your BMI greater than 35, right? And so 30, and it's yes or no. It's very objective. You go get on a scale, you get your height, and you figure out your BMI. Okay, and then where are we at? A is age, and it's a simple question. Is your age greater than 50? Yes or no. Then is N, is your neck circumference greater than 40 centimeters or 17 inches? Yes or no. And then the last question is G, gender. And so are you of male gender? And so again, it's kind of what you mentioned before, right? So it's like age and gender and all these things come into play. And so if you score on this particular second questionnaire greater than 5, you have a very high risk of having moderate to severe sleep apnea, and not just mild sleep apnea. Now, anybody who scores greater than 3, which is very easy to get, like, you know, I mean, if we're all kind of sitting there and kind of thinking about, oh, well, do I answer to these questions? If you scored more than 3, then I think there's a likelihood that you do have sleep apnea. So then what ends up happening is you usually get referred to a sleep medicine physician, and they see you, and they generally get something that's gold standard for diagnosis of sleep apnea is a polysomnography or a sleep study, as it's called. And it's preferred to be done in a lab. It's 6 to 8 hours. Yes, it's annoying. Yes, you got to go sleep somewhere. But now we do have many centers who will offer that at home as well. But and it is valid, the home sleep study, and sometimes insurances will dictate which one you get, sadly. But at the same time, the most validity is in the lab-based sleep study. And then the sleep medicine physician will sit there and evaluate all 8 hours of sleeping. And so for that, yes, you have to prepare. You don't have to prepare for it per se, but you go there and, you know, they're monitoring everything from your sleep rhythms to your breathing and to how much air you're inspiring, how much air you're breathing out, expiring, you know, what are the periods that you're stopping breathing in seconds. They're looking at volumes, you're looking at your heart rate, you're looking at your oxygen saturation. And so based on the sleep study, you come up with this apnea-hypoapnea index. So apneas are like complete obstruction of the airways for a certain period of times, greater than 10 seconds. Hypoapneas are partial obstruction, which leads to either arousal. You may not realize that you're waking up, but your body is. And so you come up with this apnea-hypoapnea index. And then based on that, you categorize somebody as not having sleep apnea or mild, moderate, and severe. And so if the mild version in adults is basically 5 to 15 apnea or hypnoapnea episodes an hour, right? So you're stopping, that many times. Moderate is 15 to 30, and then greater than 30 is severe sleep apnea. It's like you're stopping breathing 30 times every hour while you're asleep. That's pretty bad. And so and then once that happens, generally the sleep medicine doctors will start counseling you. It's like, all right, how are you sleeping? Are you sleeping on your back? Well, please sleep on your side. Weight loss, exercise. You try to figure out which ways, like especially for patients with mild sleep apnea, I think there's a good chance that changing your lifestyle to an extent may significantly reduce your risk of this worsening. Other things that we don't pay attention to is like people who smoke have a high likelihood of having sleep apnea.
Yeah, that makes sense.
And then drinking alcohol at night or using sedatives, yes. There's a lot of data in the sleep apnea literature that talks about women, particularly women saying that they cannot go to sleep or stay asleep, and which is a really good indication for having sleep apnea. And so how do we treat that in a general, like if we don't correlate all these things, you say, oh, well, here's some sedative, you'll be able to go to sleep. But I mean, all we're doing is just making things worse in reality, is that now you're having apnea episodes that you're really not going to wake up quickly from, and you're going to be sleeping even deeper. And so I think diagnosing it is very important. And so not consuming alcohol before you go to sleep, or taking a sedative before you go to sleep, and stopping smoking. All those things are some modifications that we can do to prevent a lot of these things. But most of our patients will end up being prescribed something called a CPAP machine. Mm-hmm. And everybody kind of has heard of this machine, knows somebody who's got this machine. They may not use it, but we know that this machine exists, and it is a continuous positive airway pressure machine. So it's basically what it's doing, it's stenting your airway by pushing air into it, and the sleep medicine doctor will titrate it. It's an amazing device. It works really well. It's basically a cure for sleep apnea. The problem with it is it's a device, and so it requires upkeep, and also it requires you to keep it on your face. Mm-hmm. And you have to use it every day. Like you brush your teeth before you go to sleep, it's the same thing. You got to put this device on before you go to sleep. So it's not the most comfortable of things. Now the modern devices are much more smaller and more comfortable, but at the same time, it's a thing. And so unfortunately, 50% of the patients who are prescribed this thing will not wear it past a month. It doesn't matter how much education we try to do, because it's not comfortable. It's a challenge to use, and that doesn't mean that we should use it. If you are good habits, we have amazing patients who've used it for decades at a time, and it works really well. And so if you can use it, I think that's the best, because it's the least invasive thing that you can do. And so, but people who cannot tolerate a CPAP machine, then we kind of move to a secondary modality of non-surgical management, for example. And the secondary modality of non-surgical management requires some dental and prosthesis, dental-related prosthesis, I should say. And what they're modulating, these prostheses, they're made by dentists. Mm-hmm. And there's plenty of them that you can buy online without a prescription. I don't think that's a great idea, because those will move your teeth and your jaws to a place that it's very hard to fix later. But we have some amazing dentists in town who do a lot of sleep dentistry, and they will make these devices, and you can titrate them. You can basically change how much forward basically what they're doing is they're allowing your jaw to be held forward. So basically depending on where the obstruction is, that you can have more air kind of go through your airway. And so, but again, it has upkeep, it has a cost, and it's another device that needs to be. It's like we have plenty of patients like, yeah, I had one of those made, but I see it on the floor every morning when I wake up, and it's like, well, it's hard to take care of a lot of times. So yeah, but those are kind of all the non-surgical modalities, and it's kind of how most of the patients will kind of go through this, and then eventually the sleep medicine doctor will be like, look, yeah, you're not going to wear your CPAP. I think we need to send you to somebody. But again, not every patient is a surgical candidate, and we may send some of them back and be like, look, you're not a great surgical candidate. I'm sorry, it's just this is not. All these surgical options are not for you. Yeah, sure, we can put a tracheostomy in any patient, but that has its own side effects and has its own issues that it has to deal with. And I certainly am not saying that that's a good treatment for sleep apnea, but what I'm trying to say is that we can't offer all these surgeries to every patient. And there are certain patients that will send back to me like, look, you need to be more compliant with your CPAP. I'm sorry, it's just kind of how it is. And at that time, we can then venture into the bariatric surgery and more invasive surgeries we haven't talked about yet. It's something called a transoral robotic surgery, where we reduce the base of the tongue. It is a morbid surgery. It is difficult to recover from that surgery. We do it for specific patients with very specific areas which are obstructed. It's basically in the base of the tongue. It's where the epiglottis meets the base of the tongue, and we remove a strip of tissue right in that area, and then we remove all your lingual tonsils. It might have been a really easier surgery to do on a child because their recovery with a lot of these surgeries is much easier, but in adults, it requires significant amount of downtime, so yeah.
Wow,
Yeah.
okay, so that was going to be my next question for you, is about downtime.
Yeah.
And are these various options covered by insurance generally?
Yeah. Let me answer the insurance questions first.
Okay.
I think most surgery, if not all of it, is covered by insurance. Most of the insurance, obviously, I can't speak for all insurances, but sleep apnea is an illness that is well registered, and if diagnosed correctly, the insurance companies are aware that this is not one of those things where it's like, oh, it just hurts, and yeah, we're not going to cover this part because your back hurts or something like that. It is covered by insurance. Now, there are certain things like the dental prosthesis. That is a newer thing that's coming in. Yes, they're doing more studies, but we don't have a lot of data to support it. And with most insurances, they may be hesitant to cover just the dental prosthesis part of it. And so I think that might be an issue. But yeah, insurances should cover it. And then from a downtime standpoint, it's just, again, goes to what kind of surgery do we do, right? So if we do the Inspire device, for example, like a hypoglossal nerve stimulator, which moves your tongue every time you breathe, right? And so downtime for that's about 2-3 weeks. If we do move your whole facial skeleton forward to allow for increased passage of airway, in adults, kids, maybe 3 to 4 weeks. In adults, it will probably take about 6 to 8 weeks of downtime. It's a morbid surgery, but the thing is it is very high cure rates and very high success rates, and so it will cure your sleep apnea to a great extent. So yeah.
All right, so if people are thinking they may have sleep apnea and need some of the things that you're talking about, how can they reach you and find you?
Yeah, they just call our office at Willis, Knighton, and we'll be happy to see them. Yeah, absolutely.
All right, and again, sleep apnea is something that's we often joke about snoring, but it's a serious problem that cannot be ignored.
Absolutely, yeah.
And sometimes we do, don't we?
We do, and it's sometimes we kind of just put it in the back end, and it's like, yeah, it's not affecting me on a day-to-day life, but it's constantly affecting you long term. So I think it's very important to at least get the process started. Bring it to your attention at your next visit when you go to your primary care doctor and say, hey, look, I'm having these symptoms. Do I have sleep apnea? And I think that'll be a good way to start.
All right. This has been very informative. Thank you so much for joining us.
Yeah, thank you for having me.
And thank you to all of you for joining us for Healthline 3. Have a good day.